What are health disparities and inequalities? So, to start, we should begin with health disparity. Health disparity is a recognition that health and disease are unequally distributed across populations. Health disparity means that there's differences in healthcare between populations. Health disparity means that there are genetic predispositions, biological and lifestyle factors, diet, drugs and alcohol use, sedentarism, and so on, that lead to health outcome disparities and differences. We can think about examples of this. Global cancer, for example, is highly disparate. For 2020, in the World Population Review, you can see here that cancer is not distributed across the globe equally. Certain areas such as Australia, Europe, and North America have much higher rates of cancer than places like Central Africa. In another example, we can think about national level disparities. So in Indonesia, one type of cancer, gastric cancer, is also very disparate in its distribution. You can see that some populations, for example, the Aceh population, is at low risk for gastric cancer, but other populations, such as southern Sulawesi populations like the Bugis people, Timorese populations like the Rote, and Papuan populations are at high risk for gastric cancer. We can also think about health disparities in terms of global doctor-patient ratio. In a 2021 study by the World Bank, drawing on data from 2019, you can see great disparity between medical doctors per 1,000 people. Low doctor-patient ratios you can see in places like Central Africa, West Africa, South Africa, as well as Southeast Asia and Oceania, and places with high doctor-patient ratios, places like Mongolia and Russia, Europe, North America, and South America, particularly Chile. Another way to think about these health disparities are at the national level. So if we think about the context of China, we look at doctor-patient disparity. You can see there's a great disparity between the eastern part of the country and the southern part of the country, coastal areas, and the inland areas and border areas in the north and western part of the country. A lot of the doctors in the country are concentrated right on that eastern area, and places like Tibet, Xinjiang, Inner Mongolia have much lower doctor-patient ratios. This is a form of health disparity. We can also think about the biological and genetic dispositions. So if we think about global sickle cell anemia disparity, we can look at the global map and see that sickle cell anemia is not distributed equally throughout the world. There's a great deal of disparity. So we can see high levels of concentration in places like West Africa and Central Africa, but much lower distributions in places like Iran, areas of the Middle East, Alaska, and North America. Another health disparity, right, is in lifestyle issues. We can think about tobacco consumption at a global level, and it isn't distributed equally across all countries. We see that certain countries, like the Russian Federation, have a very high level of tobacco consumption, and other areas of the world, India, let's say, areas in the Horn of Africa have very low rates of tobacco consumption. And here you can see this study from Washington Post in 2012. So in contrast with health disparity, there's the concept of health inequality. And so this term emphasizes the causal role of social inequality in producing health disparities. So for those who study health inequality, they're interested in the ways that things like unemployment, poverty, food insecurity, political marginalization, and the quality of the built environment, that is housing and other urban infrastructure, are determinative in health outcomes. This approach tends to critique the idea of genetic predetermination, other biological factors, or the lifestyle choices of individuals or communities in determining health disparities. Here, the emphasis is on political and economic factors. So you can see this study by Freeman et al. In 2020 shows a correlation, right? Strong correlation between life expectancy and the GDP per capita gross domestic product per capita, per household, in 2017. And you can see that countries here, Ethiopia being the clearest example. If a country like Ethiopia has a lower income, lower GDP per capita, you see that it has an also lower life expectancy. Countries like Brazil with a higher GDP per capita have a higher life expectancy. The trend here is very clear. Those countries with the highest GDP per capita have some of the highest life expectancies from birth. Those with the lowest GDP per capita have some of the lowest life expectancies. This would be an example of health inequality. We can think about the correlation between health and social problems and income inequality. So in a study by Pickett and Wilson from 2014, you can see that countries that have high levels of income equality, such as the United States and Portugal, also have some of the worst indexes of health and social problems. Other countries, like Japan, Norway, Finland, and Sweden, have very low levels of income inequality. That is, the distribution of income in the country is more equitable across the population. And thus we see they have a better index of health and social problems. Again, this is an example of health inequality. We can also see persistent poverty in the United States. We can think about health inequality in relationship to poverty in the US. So in this map from the USDA, you can see persistent poverty, often multi-generational poverty. You can see it concentrated in areas of Appalachia, Kentucky, West Virginia, for example, there. You can see it concentrated in the Mississippi River Delta and other areas, southern Texas, for example, the Four Corners, or southern Utah and northern Arizona and New Mexico, areas where there is persistent poverty. So now we can think about poverty, this economic factor, right, in relationship to various kinds of health outcomes. So in this particular CDC map, we see cancer deaths in the United States, deaths per 100,000 individuals in the population. And you can see some of the highest rates of cancer deaths are also distributed in the Appalachian area of Kentucky and West Virginia. You can see it in the Mississippi River Delta. This is an example of health inequality when you see the interconnection of income inequality, poverty, and a health outcome, a prevalence of disease such as cancer. In this example, we see diabetes deaths. And again, we can see a concentration of diabetes deaths also in areas where there are high levels of poverty. So in this data collected from the United States Diabetes Surveillance System for 2013, you can see that the high concentrations of diabetes also are focused in areas where there are high levels of poverty. Finally, heart disease deaths. You can also see that the same areas of that multi-generational and persistent poverty are also areas where there are high heart disease death rates. In the data there from the Center for Disease Control, you can see a clear correlation, right, between what we saw for concentrations of economic inequality and poverty and heart disease death rates, this data being for 2018 and 2020. So the health inequality is a really important approach in anthropology. Health inequality for anthropologists isn't just about understanding medicine and health to understand the human condition, the human experience, but it's also part of the application of anthropology to solve human problems. And health inequality for anthropologists is a problem. It's unjust and it's unfair. So anthropologists tend to focus on approaches towards health equity, trying to lessen avoidable disparities. They attempt to try to, through things like teaching medical anthropology, to value health as an essential resource and to encourage more investment in health as a public good. To get here, we're going to require a better focus on some of the most disadvantaged groups. And this is about achieving equity, not equality. We recognize that there are genetic predispositions and biological factors. We understand there's lifestyle issues and so on. We're not expecting pure equality, but we are hopeful in achieving greater equity, less concentrations and disparity of negative health outcomes. And one of the key things here, as we'll talk about throughout the course, is the need to reduce political marginalization, political inequality, as well as economic inequality, and increase access to good health care, essential for dealing with health inequalities as a problem and achieving a more just and fair world for all.